Waveform capnography. Waveform capnography. Waveform capnography, it measures ventilation. Ventilation is movement of air in the lungs during each respiratory cycle versus respiration, which is on the capillary level, the exchange of oxygen and CO2. In all patients, especially patients that are intubated, it should be a standard level of care. It's in a lot of protocols too, that if you have an advanced airway, such as an ET tube or a supraglottic airway, you must have a waveform capnography in place. It's also a really critical tool in with asthma patients and patients with COPD or any other pathological process. It's effective in assessing the severity of their illness, and once you have a treatment, it's pretty critical too, and evaluate if that treatment's effective or not. And it provides real-time information regarding exhaled carbon dioxide levels through an infrared sensor. Every time I exhale, the infrared sensor picks up the CO2 in exhaled air. And in addition to patients with asthma and COPD, it also has many effective functions outside of that, such as monitoring chest compressions, monitoring whether or not chest compressions are effective, and it can also detect respiratory patterns like chain stokes or biorespirations, hyper and hypoventilation, and it also can detect bronchospasms. Waveform capnography, it measures ventilation. Ventilation is movement of air in the lungs during each respiratory cycle versus respiration, which is waveform. In order to know what's abnormal, what's normal, it's important to know what a normal waveform is. Each waveform has 4 distinct phases. It's on basically a graph with an X and a Y axis. The Y axis going up and down represents the amount of exhaled CO2 in millimeters of mercury, and the X axis represents over time. Average adult, we all know, breathes between 12 and 20 breaths per minute, and normal amount of exhaled oxygen is between 35 and 40%. 35 and 45 millimeters of mercury. The first phase is inhalation, phase 1. Since at this phase CO2 is being exhaled, CO2 on the waveform reads 0. Phase 2 is the beginning of exhalation. Phase 1 is inhalation. Since at this phase CO2 is being inhaled, CO2 is obviously going to be at 0. Phase 2 is the beginning of exhalation. CO2 is traveling through the dead space and the airways, causing a rapid rise in the graph. In order to know what's abnormal, what's normal, it's important to know what a normal waveform is. In order to know what's Phase 3 is when the sensor receives the CO2-rich gas that was in the alveoli. This is a normal steady amount in a healthy adult, and it'll read as a plateau. The end of this peak is the final end tidal reading. It also marks the end tide of respiration. At the end of phase 3, the expiratory plateau can be seen. Phase Phase 3 is when the sensor Phase 3 is when the sensor receives the CO2-rich gas that was in the alveoli. Phase 3 is when the sensor receives Phase 4 marks the respiratory downstroke and fresh air is introduced. This brings baseline back to zero, since you're inhaling. You're not exhaling any CO2, so it's going to bring the waveform back to zero. There's a few things that are interesting to remember. That capnography shows movement through the lungs, so it's going to be kind of similar to an EKG represents electrical conduction through the heart. Capnography does only assesses ventilation, not oxygenation. Several conditions can be seen on a waveform capnography, such as hypoventilation, bronchospasms, rebreathing, and extubation can all be observed through capnography. With the hyperventilation, you're emitting more CO2 than what you're producing, such as when you're acidotic with Kussmaul respirations. The waveforms are going to be small, and end tidal readings are going to be less than 35 millimeters of mercury. Hypoventilation, your production of CO2 is greater than your elimination is marked by waves taller than 45 millimeters of mercury. Typical causes are respiratory depression from opiate overdoses. You're going to also have rebreathing, which is your capnography is never going to go back to zero, and you're basically breathing in CO2 that has previously been exhaled. Going back to waveform capnography being a standard of care, lastly, another abnormal waveform is going to be extubation. You're basically going to have a flat line. Your waveform is going to be a flat line with a baseline of zero. It's the most reliable indicator of tube placement, but you should also oscillate as well to confirm that you have a properly placed tube. Also going back to waveform capnography being a standard of care, it also honestly seems like it really can save your butt. And the patient, if anything goes wrong, such as if your breathing circulate, if you have your breathing circuit, i.e. your vent has been disconnected, if you have a blockage in your airway, if the esophagus has been intubated in your mind, if you have monitor failure, you're going to go, your waveforms would be a flatline. Waveform capnography has some pretty significant use in cardiac arrest. It's going to be effective in determining whether or not CPR is effective. And in addition to a feedback device, if you're having effective CPR, your end-tidal is going to be above 10. If it's less, then you either need to have your person performing CPR, you need to coach them or swap them out because they could possibly be tired. It's also not only is it useful in an ET tube placement or supraglottic placement, spikes in a waveform above 45 millimeters can also indicate that we have a return of spontaneous circulation. This is just due to the release of CO2 from poor perfusion from the patient downtime. There are two devices that are commonly used in capturing waveform capnography. We have the one on the left that's basically nasal cannula. You hook it up to the side of your monitor, you zero it out before you place it on the patient, and it also has a connection for your oxygen cylinder. Then we have the one on the right, which goes on either in between the bag valve, your vent circuit, and the ET tube, or your supraglottic airway, and it's an inline adapter. Obviously, we're going to use the one on the left if we have a patient that's alert and awake. We put it, if they're on CPAP, we'll put it underneath the CPAP mask. If the patient's intubated or if it's full arrest, we'll use the one on the right. We use them quite often, and I can understand my chief never yells at us for using them, but he always gets angry when he's got to reorder them because they're about $20 a piece.